I'm going to quickly introduce you to our next speaker, Nick Newsad, MHSA. What does that stand for? He's Vice President of Innovation of National Healthcare Consulting with the firm Coker and author of a book, Dr. Deals. Over 20 years of experience, he's been involved with over 400 major healthcare business transactions. He's a frequent presenter and has prepared reports for numerous organizations and has been interviewed by many newspapers and publications. So let's take it away, Nick.
Hello, everyone. Welcome. I'm Nick Newsad, and today we're going to talk about all the new commercial reimbursement contract data that you now all have access to as a result of the Federal Transparency and Coverage Rule. I'm happy to say that the veil of secrecy around commercial insurance contract rates has finally lifted, and contract pricing transparency has unequivocally arrived. And this creates all sorts of interesting possibilities, not just for managed care contracting, but also for folks who do financial forecasting, strategic planning, new service line development, and even entrepreneurship. As you'll see today, the power of knowing what the new transparency data has to show us is undeniable. And once you see it, I think it'll be difficult for you to ignore. So the purpose of this presentation, first and foremost, is to explain what is the Transparency and Coverage Rule. You'll see many detailed examples of reimbursement data that you all now have access to for Washington State and Alaska. And this includes over 50 graphic charts I'm going to show you today. I'll have a story behind them, as we talked about earlier, but we're going to show real market reimbursement rates for real physician service enterprises, hospitals, and ambulatory surgery centers. We will review some interesting market reimbursement insights from other states as well, and then we'll compare what we see in other states to what we see here. Lastly, I'll go through some novel, real cases of how these new data sets are being used outside of managed care contracting. So what is the Transparency and Coverage Rule? So 2 years ago, during 2024, this federal rule went into effect nationwide. This rule required all health insurance carriers and third-party administrators to release all their health plan reimbursement data online. This rule was actually finalized 6 years ago during 2020. It just went into effect a couple of years ago in 2024. So what exactly does that mean? It means that United Healthcare, Aetna, Cigna, Kaiser, all the Blue Cross and Blue Shield plans, and all the other commercial health insurance payers must release all their in-network reimbursement rates online every single month. And they have that. They've been doing it for about 2.5 years now. So I'm going to show you a whole bunch of this data today. This data includes that they're required to release, includes every physician contract reimbursement rate, every ambulatory surgery center contract reimbursement rate, hospitals, physicians, therapists, imaging centers. It's all out there now. There's nowhere to hide. The data that's being released includes fully insured health plans, as well as self-insured health plans for which these insurance companies only serve as third-party administrators. All the individual health plans on the state-based exchanges, all that data is out there, public as well. So we have all the reimbursement rates for fully insured health plans, self-insured health plans, and state-based exchange plans. You can download them yourself from the links on the slide there. So I'm going to show you a bunch of this commercial reimbursement data right now for Washington, and we'll also look at some market data for other states as well. So physician reimbursement is up first. We're going to jump right into the deep end of the pool. There's just one disclaimer in the whole presentation, and that is just because you see that a provider has a great contract rate for a specific service that does not necessarily mean that that provider actually performs or provides that service. All it means is that they have the contract rate in their contract. So I'll give you a real example. Chiropractors do not provide chemotherapy, but they still may have a contract rate in their contract because they have the same contract as doctors. Okay. So feel free to move up if you can't see, because we have the names of your organizations up there. So this is a scatter plot of contract reimbursement rates for all Premera physician contracts in Washington, or CPT code 99214. So what this shows is the distribution of Premera reimbursement rates for level 4 established patient office visits. You go to a doctor and you see the doctor in their office. These are the reimbursement rates for that service for all Premera physician contracts. So the reimbursement rates are on the left side of the axis. You see the dollar rates there, and then the number of physician contracts at each rate is represented along the bottom axis here. This is actually a scatter plot of individual data points. I have actually just ordered it from high to low. So it looks like a line, but it's actually individual data points. So the upper half of the distribution here is dominated by these big health system medical groups, which are represented by those long flat lines. Those long flat lines represent many individual physician contract rates under the same master contract. So there's a subset, a segment of the University of Physicians group. That's the clear market leader up at the top here at 280% of the Medicare rate up here. That's what their contract rate is. It's $428. That's not the entire University of Washington Physicians Medical Group. It's just a subset of them. And then Vancouver Clinic follows them, the Providence docs, the Optum groups, and then the rest of the UW docs are in the middle there. So after you get past those big groups and you get down toward the bottom end on the right there, then you have all the real small groups and the independent docs who are, just barely squeaking out a little more than Medicare, 110, 115% of Medicare. I'll show you a few more of these. So when we switch over to Regents, on Regents now, the same exact service, level 4 office visits, things look a little different. So the publicly traded companies, pediatrics and obstetrics medical groups are leading the rates here under Regents in the upper left. They have the top 3 medical group rates in the states. That's pediatrics with an X, obstetrics with an X, those companies. The Association of University Physicians in Province are up near the top again, around 258% of Medicare and 235% of Medicare. Swedish Health System follows them, and we have Virginia Mason, the Franciscans, and so forth. And then we have the rest of the University of Washington physicians. The biggest segment of the group is that big, long blue line in the middle there. And they have a massive chunk of the Regents Health Plan at around 175% Medicare. And it really drops off as we get down into those smaller independent physician groups. I wanted to point out one thing I'm kind of surprised to see here is Seattle Children's, in the Seattle Children's Medical Group, is down at 152% of Medicare, which is kind of odd. In most markets, not all, but in most markets across the U.S., the Children's Hospital and the Children's Hospital Medical Groups are usually near the top of the market with the best reimbursement days. It's a little unusual to see a Children's Hospital Medical Group in the lower half. What's the deal with that, guys? I don't like kids in Seattle. So this is the 4th HFMA chapter I've given one of these talks to, but I can show you what this looks like in other markets too. So in the state of Georgia, which I talked to about a year ago, they have this big children's hospital, children's healthcare group, which stands head and shoulders above everybody else for reimbursement. And this is pretty common in most markets. You have the big regional children's healthcare organizations that are pulling down 300 or 400% of Medicare and just clobbering the payers. This is the state of Illinois, the largest payer in Illinois, Blue Cross. And in the upper left, in yellow again, you could see the Lurie Children's Hospital docs, again, had the second best contract in the whole state of Illinois under the largest payer. I actually met an executive vice president at Blue Cross up there who runs a bunch of their plans. And he said he loved working in Chicago because in Chicago there was 80 hospitals. And he said it's a lot of competition. He loved competition. And that's probably why 3/4 of the doctors in the state are all getting around 110% of Medicare. Just a lot of competition. The providers are very fragmented. So that's all very fascinating data, but how can we actually use information like this? How can we put it to work? So here's a timely example. There are 17 brand new telemedicine billing codes that the American Medical Association created that hit the market last year during 2025. Medicare has a statutory legal requirement that requires Medicare to pay the same rate for telemedicine as in-office services when you're allowed to bill for it. So Medicare lists 16 out of 17 of the new telemedicine billing codes on their fee schedule with the letter I for inactive. And what Medicare tells providers is just keep billing the old codes, the old in-office codes, and put a modifier on it. So we know it's telemedicine. Medicare will pay you the same whether it's telemedicine or not. However, insurance companies don't have to do what Medicare does. So at this point, I can confirm that the commercial insurance carriers have not copied what Medicare is doing in this respect. The commercial insurance carriers have implemented the new telemedicine codes. And here you can see a comparison of the in-office and telemedicine reimbursement rates for level 4 established patient visits for the largest health plans in New York, which is the big one. Illinois is in the upper right, and then Georgia's in the bottom right. And what you see here is the in-office visit rates are on top, the top line, and the telemedicine rates are on bottom. They're color-coded. And those are actually the rates for the same doctors. So if you drew a vertical line between those two lines, you're comparing the rates to the same doctor. So if we have another pandemic today, for most physicians in New York, Illinois, and Georgia, telemedicine reimbursement is going to be at least 25 to 50% lower than office-based reimbursement. I think that kind of slipped through the cracks at most organizations. As of last month, March 2026, just a few weeks ago, we do see this trend in Washington state as well. For the most part, the largest payers in Washington are paying, on average, 17% lower reimbursement rates for telemedicine services as compared to the equivalent in-office services. So we have in-office services here in blue, telemedicine in orange. Regents is the chart in the lower left. Premera is the one in the upper right. So 17% difference, 17% haircut. That's not as bad as we see in other states, but it's still a lot. Look at a few other physician services here. So other than evaluation and management office visits, there's 10,000 other professional physician services out there. And we'll look at just a handful of other physician services just to give you a sense of how the market works. So here we have 2026 Premera reimbursement rates for a large sample of OB/GYN physicians in Washington. And these are episodic payment rates for routine obstetric care. So those episodic payment rates include a long episode of time before, during, and after labor and delivery. So we have the rates on the left side of the screen there for normal delivery episodes. What I want to point out about this is that as a percentage of Medicare, you can see that the reimbursement for routine obstetric care is higher than what we saw for those office visits we just looked at a few slides ago. So these OB services start higher. They start about 140% of Medicare and go up to nearly 400% of Medicare. Regular office visits started at a much lower percentage and capped out at a much lower percentage. So the point I want to make here is that we obviously do not have the same Medicare percentage rates across all physician services in these commercial contracts. They vary from service to service. It's not like you have 150% of Medicare across the board for everything. Here's the same routine obstetric professional service for Regents in Washington. Obstetrics with an X is on top again, followed by the University of Washington docs, or at least a segment of them up there at the top. In the middle is the bigger group of University of Washington docs. They're billing under 2 tax ID numbers. I don't know why. Now, I know it's a little bright in here, so if you want to get this whole slide deck, all the charts, you want to email them to your coworkers, you want to send them to the payers, have thoughtful, constructive discussions with them. This will put it right in your inbox, the whole slide deck. So just put your email in there. It'll put it right in your inbox and you share it with your coworkers and payers and such. If you can't scan it from the back on the blue table back there, we have the same QR code. So just scan that. We'll put it right in the box. It's automatic. You don't have to wait for it. So next we'll look at anesthesiology briefly. Anesthesiology reimbursement is by far the wildest of all physician specialties. We generally see the biggest variations and fluctuations in every state within anesthesiology. All anesthesiology services are billed based on what's called ASA units. Here in Washington, Medicare reimbursement for ASA units is about $20. So we have lots and lots of bigger groups, sort of in the middle there, getting 330 to 370% of Medicare. That seems to be a pretty stable floor for most of the bigger groups. However, the 177 independent anesthesiologists in the state are that, unfortunately, that bottom line down there, all the way on the right side. They're only pulling down about 245% of Medicare. I wanted to point this out because if you work in hospital finance, and you write those big subsidy checks or collection guarantee checks to those independent anesthesiology groups, there's a real chance that your organization, your hospital organization, is getting much better reimbursement than those independent docs are. Maybe you, hospital, should bill for those anesthesiology services on behalf of those independent docs and just have some sort of professional service arrangement or contract and, not kiss off all the $10 million, $2, $3, $4 million a year. Probably worth taking a look. Under Regents, all the anesthesiology providers in the state, at least under the health plan I pulled, appear to be getting the same exact rate, which is a little unusual. So that's, again, about 200 to 45% of Medicare for this particular anesthesia service. And since everybody's getting the same rate, the left axis here doesn't show dollars. It just shows the number of docs in each group. So it's a little unusual for all the anesthesiologists in a health plan to get reimbursed the same rate. You don't usually see that, except in a few markets like Alabama. Another emerging physician service we need to keep tabs on is in-office drug infusions, injections, and in-office pharmacy dispensing. IQVIA, that's IQVIA, IQVIA reports that specialty pharmacy drugs are the single fastest growing segment of the U.S. healthcare industry. All those big MSO medical groups that private equity rolled off and built into national companies are looking for buyers now. And much to my surprise, the biggest buyers of these big private equity-backed groups over the past 2 years have been the drug distribution companies. So I work with a lot of heavy hitter deal lawyers, and I have to admit, not a single one of us saw that coming. It just happened. So McKesson, Cardinal, Cencora used to be AmerisourceBergen. They have vested interests in the physicians who order the most expensive pharmacy drugs. That's why the 8 biggest physician practice acquisitions during the past 2.5 years have all been by drug distributors, which is kind of weird. Here's the webpage for Cardinal's Specialty Networks Physician Group, and it's right there on the homepage. Drugs is very important, prominent part of their physician practice strategy. This is actually getting to be kind of an old study. They had studies of oncologists to see how many of them were in groups that were dispensing drugs out of their own offices, basically running their own in-office pharmacy or in-office infusion. Basically, the bottom line is at this point, over half of oncologists are in groups that are dispensing their own drugs, most of them. So let's dive into the transparency data for a minute and just see what is the impact of all these drugs on these private equity-backed groups and everybody's groups, really. So on that first slide that had all the big doctor deals, the first deal in the upper right, upper left-hand corner was Cencora's purchase, AmerisourceBergen's purchase of the One Oncology Medical Group during 2023. I happened to, just by chance, I talked to the One Oncology CEO, Dr. Jeff Patton, just a few months before they closed that deal. He didn't bring it up, but let me just say this. He was very matter-of-fact about their drug strategy. He just said, we're very bullish about in-office dispensing of drugs and biosimilars. That's a key part of our business strategy as an organization. Categorically, oncology administers and prescribes the most drugs to patients by total sales. The immunotherapy drug Keytruda, which you see here, was the top selling drug in the world during 2024 and 2025. And the reason it was because it gained wide popularity after it was credited with saving former U.S. President Jimmy Carter's life during 2015. So Jimmy Carter had liver cancer. It spread throughout his whole body. It was in his brain. And I think he went in AARP magazine and said, yeah, I got 4 rounds of this new drug, Keytruda, and I was cured. And I had no side effects whatsoever. So the guys at Merck in the marketing department were high-fiving and popping champagne bottles. But that's why it's the top-selling drug in the year. So what you see here on this graph is commercial reimbursement under Premera here in Washington for 1 milligram of Keytruda when it's administered in office in oncology medical groups. The standard dose is not 1 milligram. The standard dose is 200 milligrams. So the standard dose is 200 times the dollar amounts you see here. So the estimated average cost of this drug I've put in a red line. It's kind of right below the big blue line there. And if we were to do the arithmetic, which I've done in the upper right-hand corner, and you multiply out the revenue and subtract the cost for the McKesson practice affiliate here, the estimated net proceeds or net contribution margin from one of these treatments, one treatment, is going to be at least $4,200. With your revenue, subtract your drug costs, $4,200 left over for each treatment. And I'm probably underestimating that because being owned by McKesson, they probably get much better than average sales price on this drug. So they probably do very well. So those infusions for Keytruda are given every 3 weeks at this dosage. And I just picked one oncology drug, Keytruda, because it's the top selling drug. There's hundreds of drugs that oncologists and other docs can prescribe their patients. We'll do 2 other drugs real quick, and then we'll move on to surgery centers. So the top selling drug in the world in ophthalmologist offices is called Eylea. This is an injection that folks with macular degeneration get over an extended period of time. So there's lots and lots of private equity-backed ophthalmology practices. Those PE-backed practices have been bought up and continued to be bought up by drug distributors like Cencora and McKesson. It's also probably worth mentioning here in orange, you probably can't see it, but in orange near the top there is Optum. Optum bought the Everett Clinic and the Poly Clinic here in Washington. And Those two organizations under Optum have some of the best reimbursement in the state, even when they're not under United, even when they're under Premera here. You know what they're doing. We'll look at one more drug for neurology, and that's because this one's just really cool. So neurologists obviously do infusions for all types of conditions. They do infusion for multiple sclerosis, MS, Parkinson's disease, Alzheimer's disease, all kinds of autoimmune diseases. Leqembi and Kisunla are two new Alzheimer's disease drugs that are administered in neurologist offices. They're infusions. I think they just got their J-code billing codes last year during 2025. So they're fairly new. But these two drugs, Leqembi and Kisunla, are the only effective treatment we have for Alzheimer's. This is it. There's nothing else. There's no other options. It's just these two drugs. So at this level, this drug generates net contribution margin of about $240 per treatment. That's after subtract out the drug costs on at the average drug costs. Patients get treatment every 2 weeks for 18 months. So all in all, that's about $9,000 per patient in contribution margin. And that's if you get the average price on that drug. There was a great 60-minute special last year that talked about enhanced delivery methods that are coming down the pike for these neurological infusion treatments. I put the link on the slide. I highly, highly recommend you watch it. Very interesting. But these trials, which have been going on for several years now, have found that they can use targeted ultrasounds to temporarily open up the blood-brain barrier while these patients are getting their infusions. And the effectiveness of the drug shoots up like a rocket. So we're all looking forward to that. The reason we went through 3 examples of these drug infusions is because they appear to be the cornerstone of all these big doctor deals that these patent firms and drug distributors are doing. You looked at, ophthalmology, oncology, and neurology, but that's just the tip of the iceberg. There's hundreds of these drugs, and they're accelerating, with all the new technology and CRISPR. We're going to get way, way more drugs here soon. All right, we'll do surgery centers and hospitals and then some novel stuff. So here we're looking at ASC, surgery center facility reimbursement for knee arthroscopy and meniscus repair. So in Washington State, Medicare pays about $1,800 for a knee arthroscopy. This is when they stick the scope in your knee, see what's going on and fix it. So looking at the scatter plot on the left, you see the red lines, that's Medicare. And obviously, it looks like about half of the surgery centers in the state are getting less than Medicare. So remember what I said at the beginning, the disclaimer is that just because they have a contract rate doesn't mean they're actually providing the service. So I checked, and pretty much everybody below that red line, the Medicare line, they're mostly endoscopy centers, GI centers, and they're just not doing knee scopes. So you just got to keep your eye on that when you're doing this sort of market analysis. The other thing I want to point out, I have the top 30 ASC rates on the right there under Premera, and nobody in the state's getting more than 200% of Medicare. We'll come back to that. Here's the Regents in-network surgery center rates for the same thing, for knee arthroscopy. And we see some different providers in here. We see the Pro-Alliance Surgeons surgery centers. They must have 10 centers around the state. They're very prominent in Regents. I don't think they're even in network in Premera. Here's Premera surgery center reimbursement for colonoscopies with a lesion removal. The Washington Medicare rate is about $700 this year for this. We're seeing over half of the centers here, the ASCs, getting Medicare rates or less. So 100% of Medicare or less. It's the same thing I already told you. A lot of those surgery centers probably aren't doing GI. So they don't care what the rate is because it's just not part of their scope. Again, no ASCs on the right side here are getting more than 200% of Medicare. the colonoscopy. And there's Regents. We don't need to go for your. So I'm not going to sugarcoat this. The surgery center reimbursement in Washington State was really bad. So in other states, we often have surgery centers and GI centers getting, at least a few of them, getting between 400 and 500% of Medicare. Washington State does not have any surgery centers, not even a single one, getting reimbursement up there. So let's talk about those surgery centers that are getting 400%, 500% of Medicare. What do those surgery centers have in common? How could you get those types of surgery center rates? So I did this big national study of 2,500 surgery centers and endoscopy centers a couple of years ago. And he looked at Cigna's national OAP network, the Pathball network. And we found that a handful of chains, national chains, and some of the big health systems are just completely dominating Cigna and the rest of the market on surgery center reimbursement. So we looked at the same things I was talking about before. We looked at ortho knee scopes and we looked at colonoscopies. So these are the study results for knee scopes right here. So if you look at the table on the right, I know a little hard to see in the back, but if you go, 3 rows down in the table on the right, HCA, the National Healthcare Organization, HCA, is getting over 500% of Medicare for knee scopes in some of their markets, like all 9 of their centers in Miami, Florida, all 12 of their centers in Austin, Texas. At the same time, HCA is not doing that well in some of their other markets. Some of the regional health systems that had invested in surgery centers are also doing quite well, like Sutter Health in California, which is 4th from the bottom in that table. At their 35 surgery centers in California, they're getting 390% of Medicare at all their centers for these knee scopes. On the next slide, Sutter is 5 rows from the bottom, and they have 37 centers doing colonoscopy, and they block in 550% of Medicare for colonoscopies. That's more than double the highest contract rate in the state of Washington. So surgery center reimbursement has got to be like the number one factor that will make or break a new surgery center feasibility study, the success of a new surgery center. So these facilities cost millions of dollars to build. It's got to be at least $6 million now. And the interest rates are probably double what they were a few years ago. So if you're going to do a surgery center deal, I recommend you get a handle on what the market reimbursement rate is before you start building it. Because otherwise you might have to crawl on your hands and knees to one of these big national chains or someone else and ask them to bail you out. Finally, we get the hospital inpatient reimbursement. So on the inpatient hospital side, we see generally 2 different types of rates. We see DRG rates, obviously, each maybe MS DRG rates or APR DRG rates in some states. Like in Minnesota, where 3M is, pretty much everybody's using APR DRG rates. We also see, not as much, but we see still percentage of charge contracts, some of those critical access hospitals. I think they were talking about that yesterday. And what you see here are the Washington DRG rates under Premera for sepsis. That's a blood infection. So this is the payment rate for an episode of care for sepsis DRG. And some of the bigger systems seem to negotiate the same rates for all their hospitals and all their hospital unit facilities. I want to pronounce this wrong, but the Skagit County facilities are in gray near the bottom of the table, and they seem to have, at all their hospital units, they get the same rate. When we look at Providence, Multicare, Feast Health, Swedish, they all seem to have multiple tiers of reimbursement rates under the same payer, but they're different hospital units and hospital facilities. Some of their hospital facilities get one rate, some of their other facilities get a different rate. So at the top of the table on the right, you see Peace Health Bellingham in yellow at the top, with the best, looks like the best rate in the state for this one. But you see another Peace Health facility, Southwest Medical Center in Vancouver, all halfway down the table there in yellow as well. They're getting very different rates for the same organization's facilities. So geography matters. Here's the same thing for sepsis DRGs under Regents in Washington. This is everybody's reimbursement rate. It interests me very much that the University of Washington, which had some of the highest physician reimbursement in the state, was kind of flirting with the bottom quartile here on the hospital side. So that makes me wonder, was that deliberate? Was that part of some strategy? Is that an oversight? I just find it interesting. I'm not being critical if anyone hears from UW, but he can be great in one thing and not as good as something else. So here's an extreme example. For years and years now, the most highly reimbursed hospital service up through last year was something called CAR T-cell therapy. And this is the CAR T-cell therapy reimbursement in Washington State. As you can see, we got some numbers up there around $1 million for a CAR T-cell therapy treatment. I was able to verify that Swedish and the University of Washington actually do provide this service in the state. They have certified CAR T-cell therapy centers, but I don't think anyone else up there does. So you can see at the top, 10 contract rates in the state. I don't think those people actually provide that service, but they win the gold medal for something they don't do. Looking beyond Washington and other states, we can get a glimpse of some really interesting markets. So we'll look at some market extremes around the country that'll make you all feel very grateful and also very jealous. Alabama is one example of an extreme market. And I say that because Alabama has one giant health insurance company. Blue Cross Blue Shield of Alabama holds 80 to 90% market share in most parts of the state of Alabama. So nobody in Alabama can walk away from a blue contract because it represents 80 to 90% of commercial revenue. There's substantially no alternatives. So what happens when you have one huge payer? It beats down reimbursement. For the largest physician employer in the state, the University of Alabama, most of their docs in their group, it varies from specialty to specialty, but most of their docs in their group are getting between 96% of Medicare and 105% of Medicare. The big segment of their docs are getting 96% of Medicare, which is horrible. A subset of the children's hospital docs in Alabama have the best group contract in the whole state at a whopping 128% of Medicare. So that's an extreme market. In Kentucky, we see similar trends with Blue Cross Blue Shield of Kentucky. The Blue Cross Blue Shield payer out there holds about 67% of the market in the state. So it's not as strong as the Blues in Alabama, where they had 80 to 90% market share. The median rate for level 4 physician office visits in Kentucky is also less than Medicare, just like we saw in Alabama. So that's tough. I'm using some extreme examples here to make a point. It's a little more complicated than this in most states, but I imagine you get the picture. Oh, I'm on the wrong slide. Oh, okay. Well, there's Kentucky. Now, obviously, there are markets where we have the opposite situation, where there is no single dominant payer. In some states, we actually see more centralization among the provider organizations compared to commercial payers. Minnesota, Wisconsin, parts of Oregon are states where we generally see a higher concentration of provider organizations compared to the concentration of payers. There are parts of Oregon in particular where no payer has more than 30% market share. Oregon's payer market is very fragmented. So it helps providers when they're negotiating, because if they're negotiating with a payer that only has 10 or 15% market share, the provider can afford to walk away from that contract, which is the ultimate negotiating tactic. So what's the impact of fragmented payer markets? Well, the largest payers in those states are paying family medicine docs, 200% to 280% of Medicare for regular office visits. That's more than double, nearly triple what we saw in Alabama and Kentucky across all specialties. We'll skip Wisconsin. We also have completely different situations where there's just physician supply and demand shortage issues. So there are states where there's just very few residencies and fellowships in state. And this is not only a problem for patients and hospitals, this is also a problem for insurance companies. So insurance companies must maintain minimum essential health benefits that they're required to offer under the Affordable Care Act. So when we have these big holes in the insurance networks in these states, even the insurance companies will get desperate and do crazy things like raise reimbursement rates to attract and retain physicians. So if you know any recruiters, or if you are a recruiter and you're trying to recruit an out-of-state physician to leave an established practice and move across state lines, you know that that is very challenging. Unless the physician grew up in your community or the physician's spouse grew up in your community, the chance of getting them to move across state lines was rather slim for the most part. You're much better off focusing on in-state physicians who are already licensed in state, preferably within 50 miles. So if you do not have very many residencies and fellowships in state to create new doctors, you could have a serious problem. How do we know that's true? How do we know that supply and demand is affecting reimbursement? Well, aside from the obvious shortage of residencies, we have dominant payer states like Alaska, the Dakotas, Montana, Idaho. But despite the payers being highly concentrated, they're still paying unusually high rates compared to other states. Turns out it doesn't matter if the payers have dominant market share if there's no docs in their network to treat patients, or if it's not enough. So you actually cannot sell, can't, you can't sell insurance plans to employers very well if you don't have complete networks. So I'll give you a funny story. I actually met a broker for Blue Cross once, and he was a sales broker who sold Blue Cross health plans to employers. And that sales rep for Blue Cross said that there was one factor that instantly told him whether he had a shot at selling a health plan to an employer or not. When he went to an employer to do a sales pitch and their Blue Cross plan failed this one test, he had a 0% chance of selling insurance to that employer. He said it all came down to one specific doctor. Anybody know who that doctor is? That Blue Cross sales rep said that if the OBGYN of the CEO's spouse is not in network, you have a 0% chance of selling a health plan to that employer. That's kind of sexist. He should have said CEO's spouse over the CEO, but that's what he said. So health insurance needs complete networks with a full range of services to get coverage throughout their geographic area. So here you can see how the states with the fewest residencies and fellowships have bid up reimbursement for family medicine physicians higher than overall national levels. This is in spite of dominant commercial payer markets. Reimbursement is higher to attract and retain physicians. Alaska is the most extreme example of doctor shortages driving up reimbursement. Wyoming, in fact, has less docs than Alaska. But you can drive from Cheyenne, Wyoming, across the border to Fort Collins, Colorado, where University of Colorado has a big hospital. You can go all the way to Denver about an hour and a half. So you have alternatives and substitutes when you're in Wyoming, even though they have the fewest docs. When you're in Alaska, you do not have a lot of alternatives and substitutes. So you're not going to be driving here in an hour and a half. So the largest insurance payer in Alaska, which is Premera, again, has to pay more. The general surgeon reimbursement up there starts at 320% of Medicare. That's the worst contract in the state. and it ramps up to over 600% of Medicare in network under Premera. Orthopedic surgeon reimbursement for Alaska's largest payer, again, starts at 330% of Medicare, and again, ramps up to nearly 600% of Medicare. That's why all those locums can afford to fly up there 1 week every month. All right, we're getting a little short on time. We're going to skip anesthesiology and my Colorado ortho story. I think the internal uses for this data are self-evident. Obviously, you can benchmark market reimbursement rates for any type of service in any U.S. market. You can create pro forma financial projections for startup surgery centers, physician practices, novel new service lines, and you can do so with a very high level of confidence in your reimbursement projections. You can identify pricing for things that Medicare does not pay for, or Medicaid does not pay for, or doesn't pay nearly enough. And I have a few of those examples listed on the screen here. We already talked about subsidies and collection guarantee issues for hospital-based specialties like anesthesiology. That applies to all hospital-based specialties. Strategy folks can make good use of reimbursement data for new service lines and alternative payment model planning. There's capitated rates in there. There's percentage of charge rates in there. It's all out in the public now, not just fee for service. And then I'll show you a few novel examples of these. So here's a pediatric physician service here in Washington. This is reimbursement under Premera for something called well child visits. If you have kids, you know what this is. This is a special visit for a kid who's 1 year old or younger. So this is a pediatric physician service that is not reimbursed by Medicare because it's not possible for a child under 1 year old to be eligible for Medicare. So there's no percentage of Medicare rates up here because Medicare never pays for this service. So this is an example of a service for which we could only get market reimbursement rates through the transparency data. Here's another pediatric service. Premature birth interrupts the normal development of blood vessels in infants' eyes. If not diagnosed and treated in a timely manner, retinopathy of prematurity, or ROP, can result in a retinal detachment and blindness. This is actually what happened to Stevie Wonder, the piano player Stevie Wonder, who was born in Saginaw, Michigan, didn't get the screening and treatment for this, and he went blind. Is very sad. So hospital neonatal intensive care units, NICUs, have a compelling need to contract with pediatric ophthalmologists to provide these ROP screenings and treatment services. It's not really even an option now. If you have a NICU, getting ROP screenings is not only the standard of care. I think pretty much all the states have codified it into the state licensure requirements now for NICUs. The problem is that Medicaid funding for these services is wholly inadequate in most states. So hospital NICUs must subsidize and guarantee payment to pediatric ophthalmologists to get them to provide the coverage. So I wish you could see this better, but in the upper right-hand corner there is the pediatric ophthalmologist reimbursement rates here in Washington State. And the one in red is actually Washington State Medicaid. And the ones in blue are the Premera rates for real contracts with real pediatric ophthalmologists in the state. So if you're cutting checks to surgeons, that could look like a kickback. So we want to know, what is fair market value to pay those independent docs? What do we want to guarantee them to do this? Now we definitively know what the entire market pays for all pediatric services through the transparency data. So we can feel a lot better about picking our number. Fertility treatment is another novel example. So fertility benefits are now features of some employer-sponsored benefit plans. Insurance companies like United Healthcare do not traditionally cover fertility treatment as a covered benefit under the fully insured plans. However, major health insurers like United may act as third-party administrators, TPAs, for the employer-sponsored, self-funded health plans that do include fertility benefits or fertility provider networks like Progeny. So under the new transparency and coverage regs, the federal rule mandates that all covered items and services under commercial health plans, including self-insured employer-sponsored plans, that must be disclosed in the new public price transparency data. So by definition, fertility benefits are covered items and services under the self-insured plans. And as a result, commercial insurance reimbursement rates for fertility are now public. You have the rates for thousands of providers nationwide through the Progeny network. So we've never had insight into nationwide fertility reimbursement rates before. This was not something that fully insured health plans covered. But if that's a service you want to be in, that's something you're interested in doing, I recommend seeing what the market rates are. This is the last one. So I want to show you what I meant when I say transparency data can be used to identify reimbursement for brand new services. So there's a relatively new category of inpatient treatments called cell therapy and gene therapy. I already showed you the first generation of these treatments. We talked about CAR T cell therapy. The second wave of these cell therapy and gene therapy treatments is coming online right now this year. So at the end of 2023, the FDA approved 2 new gene therapies to treat sickle cell disease. Those 2 new treatments include Vertex Pharmaceuticals' Casgevy, Bluebird Bio's Lyfgenia. Drug companies and doctors are too afraid to use the word cure, but it's probably as close to a cure for sickle cell as we're going to get. So the word on the street was that the price for Casgevy was going to be $2.2 million as a hospital treatment, while its counterpart, Lyfgenia, was going to be $3.1 million. That was the rumor. I'm telling you now, we have the data. That's true. So this year, in 2026, Casgevy and Lyfgenia will leapfrog CAR T cell therapy as the most expensive hospital treatments nationwide. I predict hematology is going to make a roaring comeback. And Casgevy is what's called a CRISPR treatment. Some of you probably heard of that. CRISPR is a gene editing technique, and it's really opened up the pipeline for a lot of new treatments. We have approvals for over 40 different types of new cell therapy and gene therapy treatments for muscular dystrophy, hemophilia A and B, and several types of cancer. And we're going to need to know what reimbursement is for all these new services because they're coming online here. So I'm very optimistic about all this. There's a lot more you can do with this new data, the transparency data, than just managed care contracting. I'm very optimistic about using this sort of a crystal ball, really, to reduce and remove a lot of business risk from new service line development, new business ventures. And financial executives like yourself don't have to sweat bullets while trying to predict the future. If you know what the market is and kind of know where your place is in it, you can predict the future with pretty good confidence. So as we saw with Alabama, Kentucky, Oregon, Washington, not every market is the same. As we saw with anesthesiology, not every provider gets the same rate within the same market. There's often wild fluctuations and variations in reimbursement within the same payer, within the same market. So we have, I glossed over a lot of info real quick, but we have detailed articles and videos on all this. There's a link on the slide deck. And then, again, you can put this right in your inbox and email it to your friends and coworkers. I got 4 minutes. I'll take questions if you got any. Work-related only.
Hey there. Question for you. Do you think with the payer machine readable files now public, is this making the provider machine readable files more or less obsolete? Is there any information you can gather by bumping the two against each other?
I think the provider files are obsolete. In the payer files, you get one file and you get everything in the network. in one shot. And with the provider files, I got to go get 5,000 files. They're not formatted the same, and the quality is lower. That's my
I appreciate it. I appreciated the CAR-T slide and also the notation that there's only 2 hospitals in the state, or possibly 3, 2 Swedishes that do CAR-T, and that the rest of them all have rates because it's a derivative of the formula based on the DRG times the weights that any hospital technically does. But most of the hospitals in many of those circumstances don't provide that service because they just don't have that level of expertise, which further concentrates the um, the oncology and some of the special to only a very few number of physician groups within within the state as well. So it further concentrates that. But anyway, this was exceptional data to be able to show, and the fact of the matter is what the market is, and also just an appreciation for the whole perspective about um, the the ability the insurance company has to have some level of market to be, or as far as physician group contracted to be able to get into a market. And sometimes from the hospital side, we don't feel that that's necessarily the case, that they push it anyway. But it's nice to see that there is actual pressure, but they did go up to. So thank you.
yeah. Yes.
There's one more. You didn't get out so easily here. um, I have a quick question about the same, let's say, provider getting reimbursement in two different markets at two different levels. What is it contributed to? Like, how does it happen, and how to prevent it or standardize? What do you see in the markets?
I would go to one tax ID number for one. So that's one thing we see is organizations will have multiple legal entities with multiple tax ID numbers, and the rates are tied to the tax ID NPI pair. So if you only have one tax ID number for one, everyone's going to, for the most part, be on the same rate unless you negotiate specialty specific. So I'd go to one tax ID number, and then the other. I mean, it depends. I mean, if you're in downtown Seattle and there's 200 other folks who do what you do, you don't have a lot of options. I mean, they don't care if you go out of network or not because they have 199 other options. So it depends what it is. But simplifying your legal structure will help. Awesome. Two more.
He hired you at the late
Sure. Oh, there we go. This was eye-opening and just fantastic data. And, I could maybe have gotten this data, but I wouldn't have your insight and I wouldn't have your knowledge. So this was really fantastic. So you get my vote for best presentation this this conference. And just when they're getting paid less than Medicare, I mean there should be a law. Like it just doesn't make any sense to me. So I don't know if you have any more comments on that, but I'd love to hear them.
It's what it is. I mean, they got 90% of the market. I mean, you can't walk away. So it is what it is.
Agree with. Um, the value of this data is unbelievable. I used to do contracting for one of the largest HME and home infusion companies, and I would negotiate these contracts with United, Aetna, Kaiser. And when you'd walk in, you always had to be wondering. I had my analyst sitting right next to me because I knew by every therapy what my profit margins needed to be, what my costs were, and you had to wonder what the people on the other side of the table, the information that they were bringing in, because they didn't really know your business model to understand what line items did I need to get an increase, and others, you know what, go ahead and give me just 100% of Medicare because I don't do it. So it doesn't really make it, but you can feel good that you're cutting me down on that because it was really more volume driven. But what do you feel, that as a payer versus provider, how much data, obviously, that payer is bringing in from a negotiations perspective, except for, gee, you're the only one in town, or you've got 10 competitors that you either take it or leave it.
I'll give you a story. This is from just a few weeks ago. So we were negotiating for a small hospital here in this area. And we had signed the paperwork so we could negotiate on the hospital's behalf. So we go to Primera and we have our first call. We introduce ourselves. I actually wasn't there. It was some of my coworkers. But would say what we really want is we really want to just be paid the same as the other hospital that's exactly like us 25 miles down the road. So there's another hospital exactly like us. It's the closest one to us. We just want to be paid the same as them. And Primera said, "Oh, well, you're being paid the same as them. There's no difference between you and them." And they turned to the next slide and they said, "No, we're not. We're getting 15% less across the board." And then the Primera didn't say, "That's wrong." They didn't say, "That's not fair." They said, "Where'd you get that?" So they got caught on their hand in the cookie jar. But it's working.
Thank you, Nick.